So, for the sake of time, we will move forward. We are going to start the last session that Professor Gilev already introduced. So, we invite the first speaker to present. We don't know whether she's online or she's... you're online. Okay. So, it's my pleasure to introduce Nia Mileva again with the topic coronary microvascular disease. Does it exist?
Thank you very much. Thank you for the invitation and the opportunity to present the topic of coronary microvascular dysfunction and try to answer the question if CMD actually exists. If we take a look back to the 70s, we see the first report in the literature. Actually, it's an editorial in AGC that is actually defining this group of patients with normal coronary angiograms and angina. We see that this is really the first mark in literature when these patients are defined as group X or syndrome X. Later on in the years, this mysterious group drew more and more interest, and we see this sub-analysis of the WISE registry, a registry including women with hypertensive disease. And we see that if we compare the groups of these patients, compare the groups that are completely asymptomatic with those that have some symptoms, either with completely normal coronary arteries or with some mild stenosis but non-obstructive coronary artery disease, we see that indeed the symptomatic patients have significantly higher rate of composite endpoint, consisting of all-cause mortality, cardiovascular mortality, stroke, hospitalization for chronic heart failure, and myocardial infarction. So this really underlines the importance of angina and the fact that if we have angina, even with non-obstructive atherosclerosis in our coronary arteries, there is some problem. However, it is kind of logically that some people doubt the diagnosis of CMD because intuitively we cannot see the problem. We see that in the conventional coronary angiogram, we see the epicardial coronary arteries. However, 90% of the coronary circulation remains unseen, it remains invisible. This part of the coronary artery tree that is below 400 micrometers, the microcirculation, is of extreme importance, and we should remember that the microcirculation is not just a smaller version of the epicardial coronaries. It has different function. If the main function of the epicardial arteries is the transport, then the main function of the microcirculation is the autoregulation and the exchange of metabolites in the myocardium. So having this in mind, in the last year, we witnessed a real evolution of the definition of CMD from this mysterious diagnosis of syndrome X as a psychosomatic problem in women to real objective data of ischemia to the belief that microvascular disease is a benign condition to the final syndrome of Anoka-Inoka that thankfully today is even included in the guidelines for chronic coronary syndrome. And here I would like to have an important remark. We should really keep in mind that angina or ischemia with non-obstructive coronary arteries is not mandatory equal to microvascular dysfunction. We know that angina with or without ischemia, plus no evidence of atherosclerotic coronary obstruction in our epicardial arteries, equals ANOCA. However, ANOCA itself may include in itself microvascular dysfunction. However, it may also mean microvascular vasospasm. It can also mean epicardial vasospasm. And last but not least, we should not forget that some part of the patients have myocardial bridges. Having this said, we can imagine how interconnected is coronary microvascular dysfunction with various cardiac pathologies. We can see and find microvascular dysfunction in patients with obstructive coronary arteries or with those with non-obstructive coronary arteries. We can find coronary microvascular dysfunction in patients with acute coronary syndrome, in patients with cardiomyopathies, and in patients with heart failure with preserved ejection fraction. And then if we focus on the methods for functional diagnostics of coronary microvascular dysfunction, we can see the variety of methods available. First, if we start with the non-invasive technologies, we can have PET, we can have SPECT and MIBI. We can even use echocardiography for assessment of coronary flow reserve, and we can use cardiac magnetic resonance. If we look on the invasive groups of methods, we can use intravascular Doppler for assessment of coronary flow reserve, and we can have the thermal dilution method, either bolus or continuous, to measure coronary flow reserve, IMR, and MRR. Last but not least, we have the invasive acetylcholine provocative test for assessment of vasospasm. So all these variety of methods, you can imagine how many different thresholds for the positive diagnosis of CMD we have. And logically, a few years back, we decided to summarize all the studies that included patients with angina, with non-obstructive coronary arteries, and test for CMD. Meaning test for CMD, you can see both non-invasive diagnostic methods, bar plots in blue, and invasive diagnostic methods, bar plots in red. And I'm sure you see the same thing that frustrated us a few years ago, that there is a very high heterogeneity in the prevalence of CMD in the different studies. And this is most likely related to the different methods used, different tests with different thresholds. So here again, we can underline, we can mark the problem that also Dr. De Bruyn said earlier in the day, that from one side, we are in danger of underdiagnosing CMD because some patients just remain untested. However, there is a real danger that a lot of patients are hyperdiagnosed with CMD based on tests and methods that are not validated and that are not reproducible and are not standardized. So it's really important to find the test that is validated and standardized. However, combining all of these studies, we found that the prevalence of CMD in all of these patients, the pooled prevalence is 42%. So you see a very remarkable proportion of patients had CMD. Another thing that we found that was not really surprising and was already reported is that that female patients were nearly 1.5 patients more probable to be diagnosed with CMD. Later on in the years, there was another interesting study again performed in Aust regarding the diagnostic performance of exercise stress test for detection of CMD. And you see, we included patients with angina with positive ECG stress test that were referred in the cath lab for functional assessment of FFR and IMR. Interestingly, we saw that epicardial disease only was seen in 33% of the patients. All of the patients were with positive ECG stress test. However, when also IMR was applied, we see that 22% were positive for microvascular dysfunction, and 40 patients were positive for hemodynamically significant lesion based on FFR measurement. Therefore, using FFR and IMR, we were able to decrease the false discovery rate of positive ECG stress test to 43%. Another study published last year confirmed the same. Again, these were patients with chronic coronary syndrome with performed exercise ECG stress test. However, here we had two groups: patients that had positive results from the ECG stress test, the ischemic group, and patients that had negative results, the non-ischemic group. Then patients underwent complete functional assessment in the cath lab with measurement of FFR, CFR, and also provocative test for vasospasm with acetylcholine. What we saw that the ischemic group from the ECG stress test had 100% of coronary microvascular dysfunction. So all of these patients were actually positive for CMD. Again, very important remark that probably a lot of the ECG stress tests that were false positive in the past were actually patients with coronary microvascular dysfunction. And this is a very recent study, the VIII study, that we already discussed shortly yesterday. A study just published a few days ago that assessed patients with chronic coronary syndrome assessed in the cath lab in two groups. One group of the patients were just assessed with conventional angiography, and the other group of the patients underwent the VIII protocol, which again consisted of full functional assessment with measurement of FFR, CFR, IMR, and acetylcholine provocative test. What we see, if we apply the conventional angiography and nothing else, we can identify the obstructive cut in 32% of the patients. In the rest 68%, no cause of ischemia can be identified. However, if we applied the full functional assessment, we can be able to identify reason for the ischemia as CMD in 45% of the patient. So we see that in the last studies that I showed you, and also in the meta-analysis, the prevalence of CMD is indeed always ranging around this percent, above 40%. In conclusion, I would like to say, yes, coronary microvascular dysfunction is an actual diagnosis. CMD is related with adverse clinical outcomes. Last but not least, diagnosis should be based on reproducible and standardized methods. Thank you.
So thank you very much, Nia. Any comment from the panel or from the audience? I'm curious, when you mention that we should avoid non-standardized methods, do you have something specific in mind?
Well, honestly, for me, the non-invasive methods, we still do not have accurate non-invasive method. It's unfortunate that I should say that someone that is really working with non-invasive imaging, but until now, I don't think we have met the method that is reproducible enough and with higher sensitivity and specificity. So this is the reason why the guidelines indeed recommend the invasive diagnostic procedure for measurement of FFR, CFR, IMR.
Thank you very much. Any additional remark or comment?
Maybe one comment and one question for you, Nia. Congratulations, great talk. Would you agree to say that those patients that we would assess in the cath lab with all the assessment that you described, I mean, the first step should be to be really sure that they are clearly symptomatic. I don't know about the last paper that you showed from the group of Escaned, if all those patients were symptomatic, but would you agree to say that before going in this process, we should be quite selective regarding the patient we bring in the lab for this assessment?
Yes, I definitely agree that we should screen for patients that have angina in the first place. Of course, sometimes this is very tricky because in the end, the patient came to look for a cardiologist. The patient did not just appear in the hospital. So probably there is the reason that he came to look for a cardiologist. And we should be very critical when we take medical history and ask the patient and be sure that if there is really angina.
Thank you very much. So I think we can move to the next. We have another question.
Are there some fluoroscopic markers in a patient that has non-obstructive coronary artery disease and has angina that can suggest to you, without doing the functional assessment, that the patient might have coronary microvascular dysfunction?
Yes, the methods of the TIMI frame count and the TIMI flow is something that has shown promising results in the past and definitely has a lot more to explore in this area. So this is another method, but again, it's an invasive one.
Thank you. And some other things like coronary ectasia, the slow flow, or sometimes when you hold the fluoro a little bit, you see some coronary cameral microfistulas, and these patients often have angina and have some ECG changes as well. in some patients, I think this can explain the findings as well.
Yeah, I think the fistula and some anatomic variants probably are another source for rare, which is a little bit out of the scope of Nia's presentation, right? But thank you for the comment. That is missing in the global picture. Thank you.
Yeah, thank you. I think we can move to our next speaker. That need no introduction. Bernard, please, about IMR. Quick and easy, question mark.
Okay. Okay, good. So thank you. I will try to keep it relatively brief because this is very technical and that we discussed already and we tried to demonstrate this morning what is IMR. But actually, bolus thermodilution, I realized this morning when making this poll, is not really very widely applied here in Bulgaria. So maybe we should go through the basics of what is exactly bolus thermodilution. Now, the goal of the whole story is to measure the resistance of the microcirculation. This is really the goal, the aim. Now, we will come back later on the qualification of this microvascular resistance, but okay, let's keep it simple. What we want to have is a surrogate of the resistance of the microcirculation. And when we think and we say thermodilution, actually there are two types of thermodilution. The only one we are going to focus on now, during the next 10 minutes, is bolus thermodilution. You have seen this morning that there is also continuous thermodilution. Let's focus on bolus thermodilution. You have seen this morning when we inject the bolus through the guiding, a bolus which is a little bit colder than the blood of the patient. Well, the sensor, the sensor of the tip of the wire detects a difference in temperature, and this is a thermodilution curve. Now, thermodilution curve, well, think of it. This is exactly what we also see when we do cardiac output. When we do cardiac output in the cath lab, we inject 10 cc of saline in the right atrium. Who does cardiac output still? Show of hands. In Italy, one, and in Hungary, but in Bulgaria, no cardiac output. Alain, Yves, no cardiac output. It's a long time ago. Okay, good. Anyhow, theoretically, you should know what cardiac output is. You inject 10 cc in the right atrium, and then you see at the tip of the Schwann-Ganz catheter what happens with the temperature. And this is also a kind of tracing that nobody look at, but actually here, okay, I see that you do not see the pointer on the screen, but okay, actually here you have a thermodilution curve, and this is exactly the same that we are doing in the coronary arteries. There is also an assumption that I would like to emphasize. When we do cardiac output, and I'm sorry, I know you don't do cardiac output, but when we do cardiac output, we assume that the bolus administration is instantaneous, which of course it is not, because it takes some time to push it through. Second, we assume the temperature is 0 degree. So by definition, it is not really 0, it's probably 1 or 2 or 3 degrees, but not 0. And third, and that's the most important deviation from the assumptions, we assume that the mixing is instantaneous. This is not the case. So these are all possible errors that we perform when we do cardiac output, and these are the errors which are, let's say, which has as a consequence that, for example, all the calculations that are based on cardiac output measurements are actually flawed, including aortic valve area, for example. That's just an example. Just to tell you that this thermodilution has a lot of assumptions that are actually not very often respected. Now, in the coronary arteries, it's a little bit better. And it goes like this. When you have a coronary artery, I will try to have it moving, but I'm not sure it works here. Okay, anyhow, when you have a coronary artery like this one, I will try to point it. Yeah, okay, let's have this coronary artery here. You have the left system, this is the wire, this is the sensor, and this is a thermistor. You have to realize that the wire in itself have two thermistors, two sensors. One is the micro tip manometer at the distal end, this one, and the second one is the whole shaft of the wire, which means that when we inject saline in the guiding, the shaft will say, hey guys, it's getting cooler here, and then a couple of seconds, well, 1 or 2 seconds later, the sensor will also say, hey, it's getting cooler. So there are the creation of two thermodilution curves. One, the first, from the shaft, and the second one from the distal part of the wire. Actually, on the screen, and I will go to the illustrations, on the screen of the coroventis, we see very often only one of these two thermodilution curves. This is a tracing that we produced a little bit artificially, but showing that actually each time there are two thermodilution curves. And the reason why we need two thermodilution curves, not we, but the computer, is to say this is the moment where the injection took place. You see this deflection here, and this is the time where, or at which, the bolus reached the distal part of the vessel. Is that clear? That's very important to understand. So this is the mean transit time. And when we say that the resting mean transit time, the average value is 0.76, it simply means that it takes 0.76 seconds to travel from the guiding to the distal part of the vessel where the sensor is located. You imagine you put yourself in the shoes of a red blood cells, and it takes less than 1 second to go from proximal to distal. That is the mean transit time. And of course, if you travel very slowly, the mean transit time will be very long, and therefore this corresponds to a very sluggish flow. When it goes very fast, the mean transit time will be very short, which means that the flow velocity is higher and that therefore the flow is higher. But you also understand when I say this, that this mean transit time is only a surrogate of flow. It is not absolute flow. It is not what we have demonstrated this morning in the cath lab. So it is just a kind of proxy of flow. Nevertheless, it can be used to define two things which are important for the diagnosis of CMD, as Nia already told us, namely CFR, coronary flow reserve, and IMR. CFR, is that clear for all of you what it is? CFR, of course, okay. CFR is the ratio of hyperemic flow divided by baseline flow. It's therefore the number of times we, or the patients, can increase his flow above the baseline. Now, when we are dealing with mean transit times, it is exactly the reverse of flow, and therefore it is the CFR is the mean transit time at rest divided by hyperemia. It's the reverse of this one. It's a detail, but it's of course very important to understand. And I will actually almost finish with a couple of examples like this one. This is a typical example at rest and during maximal hyperemia. Here you have the tracings at rest in blue. They are slower. They take more time, okay? The transit time is longer. The flow is lower at rest. Normal, absolutely normal. We induce hyperemia with papaverine, for example, or with adenosine or whatsoever. The transit time is suddenly much shorter, and the average value is 0.26 as compared to, let's say, 0.80. So 3 times faster. There is an increase in flow velocity by a factor 3, which means that coronary flow reserve, I will show it there, equals 3. That's the principle. Okay, that's the rule of the game. Now, there is another index I promised to go through very, very quickly. It is IMR. Again, I highlight hyperemic and resting flow. This is IMR. But we also are able to calculate IMR, and the IMR stands for Index of Microvascular Resistance. What is resistance again? Let's look again to the Ohm's law. It is the reverse of flow. Here, Ohm's law, we are going to reshuffle this equation. Resistance is pressure divided by flow. Well, actually, with this mean transit time, we have a kind of surrogate of flow. And we have, of course, the distal pressure. It is given by the wire. So therefore, we are going to derive not really the resistance, but an index, kind of surrogate of resistance. That's the IMR. Is that more or less clear? I understand it's a little bit complicated, especially if you have never done it yourself, but I can tell you in the cath lab, this is really peanuts. Just a syringe of 3 cc, you inject it, and you have your mean transit time. So the IMR is actually P multiplied by the mean transit time, because here in the denominator it appears as a ratio. That's it. And again, I would like to finish with this example. I think it is the same example. You have seen that we were able to calculate the coronary flow reserve, 3.1. Well, we are also able to derive the IMR, and the IMR is what? It is the mean distal pressure multiplied by the mean transit time during maximal hyperemia. So distal pressure is here, okay, during maximal hyperemia, multiplied by 0.26, and this gives us, in this patient, 24. That is how the IMR is produced. And again, IMR is an index of microvascular resistance, okay? So bolus thermodilution equal mean transit time. Mean transit time, you can calculate coronary flow reserve, and you can calculate IMR. And these are the indices on which are based 90% of the diagnoses of CMD nowadays. This is the most often used index. It is not the most reproducible and the most accurate, but it is the most used for the time being. Good. So in conclusion, 1, bolus thermodilution allows to measure the mean transit time. I think you understood that. We have repeated that 10 times. From the mean transit time obtained at rest and during hyperemia, we can derive CFR, coronary flow velocity, coronary flow reserve. And from the mean transit time during hyperemia and distal coronary pressure, which is the pressure at the entrance of the coronary microvasculature, we can derive IMR, which is microvascular resistance. I will stop here. Thank you very much. If there are questions, I'm still here.
You said thermodilution assumes 0 degrees injection. Is there any difference? Because during the live case, I think we used a room temperature saline. Is there any data if the accuracy is better?
Oh, no. I made a
water?
mistake. I made a major mistake. If I say that, I apologize. I was alluding to the thermodilution that we use for cardiac output.
Okay.
You know that we take saline in iced content. Huh? If you do the same in the coronary arteries, what will be the result? Let's put the question there. You take saline at 0 degree from the fridge. You inject a bolus of 3 cc in the coronary arteries. What will you obtain? What will happen with the patient?
Ventricular fibrillation.
Spasm?
Spasm.
Fibrillation? Might be. Also. Okay. AV block, that's even closer to the reality. But actually, if we inject suddenly a very cold saline in the coronary artery, we are doing nothing else than what the surgeons always do, cardioplegia. It's cardioplegia. You do that, we did that in the beginning. You have a flat line over 10 scopes. You'd better have a pacemaker in the neighborhood. Okay? So never do that, of course. That's good for cardiac output, but never for coronary thermodilution. Coronary thermodilution, to come back to your question, is of course, Adrian, you know it, performed with saline at room temperature. And room temperature is very often 10 degrees lower than the body temperature. Nothing happens with that. You can go up to 16 degrees, 15, 16 degrees. Nothing happened. Below, you have AV blocks to start with, and very often, very quickly thereafter, lower, you have no electrical activity anymore.
A question I always wanted to ask is, what's the influence of the position of the wire, of the thermosensor? Because I guess, for instance, for the relation, for CFR, probably plays a minor role, but for the resistance, since we are using the absolute transit time, probably it will play a bigger role.
Well, you know, the politically correct answer is put your wire in the distal third of the vessel at a minimum of 6 centimeters distal to the guiding. But you're absolutely right. There is a difference. If you come back, you will see your mean transit time decreasing. It's absolutely logical. And as you state very, very truly, very correctly, it's not a problem when you do rest and hyperemia, because you're correct for that. But if you just do hyperemia, like in IMR, you influence the measurements. That's only one of the multiple factors which influences IMR.
Sorry. Do you think that TV flow count can be some substitute for speed of contrast instead of measuring just timing? Because TV flow count after adenosine can give you something like a CFR without even having a wire inside.
Well, what to say? It seems to me a very rough method to do, because you really have to count to see the appearance of contrast in the guiding, then in the left main, then in the proximal LED, and so on and so forth. And then you count and you say 1, 2, 3, 4, 5 beats, and it reached to distal LED. That's Timmy frame count. You agree with me? Is that what you mean? Yeah, it seems for me a kind of rough estimate of the mean transit time. I fully agree. It's exactly the same information, but maybe a little bit more amateuristic. Now, this being said, for many, in many respects, I think that Timmy frame count might well be more precise than mean transit time, for all the reasons we are alluding to: the distance of the position of the catheter, the mechanical interaction of the operator. That's a massive factor. If you inject very briskly or very slowly, the computer will tell you error, or injecting, what is it again? Error in slow injection. You will feel that, but nevertheless, you can influence the mean transit time dramatically simply by your interference. But basically, again, to answer your question, it's more or less the same information.
But to go a little bit more in that direction, we have all those companies coming now with a so-called angio-IMR, derived from angio, right? And as Emmanuel said very well, there is a temptation to use those indexes to do the diagnostic. So any comment from you regarding those software, those indexes?
Well, I think the presentation by Emmanuel was very complete and was better than what I could tell in 2 words. I'm not a big fan, of course, of these approaches, because there are so many assumptions, not only border detection in one projection, maybe in a second one, the 3D reconstructions, the segmentation. I look at Tabo, he's an expert in segmentation of the coronary arteries. The segmentations of these vessels is very tricky, so the identification of all the vessel. And then in addition, there is this Timmy frame count, which is sometimes really a Timmy frame count, sometimes a little bit more sophisticated. But there are so many assumptions that for me, it's not a big surprise that the correlation is very, very vague. But, okay, maybe I'm a bit biased.
So maybe last question, just to proceed.
Yeah, thank you very much for this talk. Considering all the technical drawbacks and possible pitfalls, and also the fact that we really have no big data on what a normal IMR should be. because we assume that it's 25. But if we go to the literature, these are series of 20 people, 30 people at most. I mean, we don't have really big data. So how do you think, it's of course not related to this talk only, but in general, so in an ANOCA clinic, if you see patients with some type of chest pain or some pain or some shortness of breath or any other complaint, so some complaint, and you have a normal angiogram, a normal FFR, and then IMR of, say, 27 or 30 for that matter, how secure do you feel to put these patients on medications to
for the rest of their
ischemia?
life?
For the rest of their lives, exactly.
Yeah, that's a good question, a very broad question. Actually, the IMR has been relatively well validated in a very small subset of patients, namely acute myocardial infarction. Now, you are all used to treat patients with STEMI in the middle of the night. You open the vessel, and then sometimes you see persistent sluggish flow, sometimes really very sluggish. And we all know that when there is sluggish flow after reopening the LAD, that's not good. That's not good for the patient. The ejection fraction of this patient will decrease, the prognosis is worse. And actually, sluggish flow means very long mean transit time. If you do that in these patients, and you validate that in these patients, it's not a surprise that you will have very tight correlation between IMR, based on the mean transit time, and clinical outcomes, poor outcomes. Now, this is the main group in which IMR has been validated. The same has been tried in stable patients, stable complaints, but no STEMI. And there, the correlation is much, much weaker. There is a kind of consensus in the literature to say, well, the borderline, the threshold must be around 25. I fully agree with you, because this is what I heard or understood between the lines. This is a very vague threshold surrounded by a very large gray zone. In our practice, I would say, or in my interpretation, I would say, if you see a patient in whom there is a very narrow mean transit time, and that the IMR is below 13, 12, 10, then you can be almost certain that there is nothing wrong with this microcirculation. In contrast, if you have at rest a patient with a very long mean transit time and that your measurements are done properly, with a transit time of, let's say, 1.2 seconds during hyperemia, that is definitely a problem. Then there is definitely a problem. But in between, and the in between is 80% of the patients, you simply cannot say anything.
Thank you very much, Professor De Bruin. It's been a pleasure, a privilege listening to you. We will spend the whole evening just on these topics. But right now we'll move to the next speaker. Let's invite Dr. Tabu Mahendiran to talk about the presentation entitled Coronary Flow and Resistance in milliliters per minute and in Wood units.
Thank you very much. It's a bit odd doing this presentation now, because this is the theoretical presentation about continuous thermodilution and the assessment of absolute flow and resistance, having already done the practical demonstration in the lab earlier. But hopefully I can consolidate some of the stuff we spoke about and maybe clarify a few misunderstandings along the way. So the key things that I'm going to talk about are the technique of continuous intracoronary thermodilution and how it allows us to measure absolute flow and absolute microvascular resistance. So that's different from the stuff we've been speaking about before, which are proxies. We're going to be measuring flow in milliliters per minute and resistance in Wood units. I'm then going to talk a little bit about the accuracy and the precision of this technology and why we can trust it. And then before moving on to how we can use it to evaluate the microcirculation in patients with ANOCA in preparation for the subsequent talks that are going to come. So, we spoke about Ohm's law earlier today, and I think it's such a nice thing to have in mind when you're thinking about coronary physiology, but it's such a good analogy when we talk about flow and resistance in the coronary circulation. So you know that voltage is equal to current times by resistance in an electrical circuit, and it really does work for the coronary circulation too, where the pressure gradient across the coronary circulation is equal to the flow in the coronary circulation multiplied by the total resistance. And as Bernard spoke about earlier, we're talking about resistance in series from the epicardial compartment, so the epicardial resistance added to the microvascular resistance. And why is flow important? Well, for coronary physiologists, flow is everything. So we spoke earlier about the correlation between flow and myocardial function. The coronary circulation is doing absolutely everything it can do to maintain stable flow. That's the premise of coronary autoregulation, the plateau of flow despite epicardial disease. Soon as that flow starts to decrease, you start to get myocardial dysfunction in the area subtended by that artery. So flow is critical for coronary physiology. We've spoken about some of these other methods of evaluating flow in the coronary arteries, but actually, are we measuring flow is the question. So on the left-hand side, we have Doppler, intracoronary Doppler. Is intracoronary Doppler measuring flow? Well, technically not. It's measuring velocity. It's measuring the velocity of blood as detected by a Doppler probe inside the artery. If you want flow, you need to turn that velocity into a flow rate in milliliters per minute. And so you need to multiply by the cross-sectional area of the vessel at the exact site of that Doppler sensor. Now, we don't usually have that information at hand. People often use software packages to reconstruct the coronary artery to work out what that cross-sectional area is. You don't have intravascular imaging at the same time that you're doing your measurements. You can't really know flow. You can just know the velocity. We then have bolus stem dilution. Bernard gave a great talk about this and how this works. But again, this is a proxy for flow. So we're looking at the mean transit time of a bolus of colder saline through the coronary circulation. And we're using this as a surrogate for what's happening in terms of flow in the artery, but it's not the same thing. So the principle of continuous thermodilution is essentially this. To perform the measurements, you have your guiding catheter in your artery. Here we have the left coronary circulation. And we put a pressure wire, like we did in the live case earlier today, distal in the vessel. This pressure wire also has a temperature sensor at its distal point. So we have a lot of information at the same time. We're then going to advance this dedicated infusion microcatheter, the ray flow catheter, and we're going to position it in the proximal artery, and it's going to infuse saline. Now, some key points about this catheter: it is very, very specifically designed for this function. It has 4 side holes, and the key about this is it ensures the instantaneous mixing of the saline being infused with the blood. And so by the time we have the mixture of blood and saline being picked up by the distal sensor, we have a homogeneous mix of blood and saline. That bit's really critical. And so what can we do with this information? Well, we can use this validated equation to turn the various parameters we know into a flow rate. So flow, the annotation is Q, can be calculated if we know the infusion rate of saline at the tip of the ray flow catheter, which we know, it's something that we program. So earlier today we showed you that to get resting flow measurements, we program this at 10 milliliters per minute for the LAD, and for hyperemic measurements, we program this at 20 milliliters per minute. So we have that. We have the measurement of the mix of blood and saline, this homogeneous mix of blood and saline in the distal vessel that we're going to pick up with our distal temperature sensor. And then we have the temperature of the saline at the tip of the ray flow catheter before it enters the artery. And we got that. It was Dr. Valerie Geller who pulled the temperature sensor back to the tip of the catheter to pick up this measurement. Then we're going to multiply by this constant, which in short is to adjust for differences in the property of blood and saline. And we're going to be able to calculate a flow rate in milliliters per minute. I hope that's clear. To make it even clearer, let's run through some numerical examples. Okay. So let's imagine we're trying to measure resting flow in the LAD. So as I said before, we're going to use a flow rate of 10 milliliters per minute being infused by the ray flow catheter. And we're going to pick up the temperature of the mix of blood and saline distal in the vessel. I'm going to hammer home another point, or 2 points here. One, the temperatures that we're measuring here are relative to the temperature of the bloodstream. So before we started our infusion, we zeroed the temperature sensor so that it was the same temperature as the blood stream. So every measurement we do of temperature now is going to be relative to blood temperature, hence why all of the measurements we had earlier were negative, okay? So we have a distal temperature of a mix of blood and saline that's minus 0.5 degrees below blood temperature, okay? So we can plug this into our equation. We're then going to pull back the temperature sensor to the tip of the ray flow catheter to pick up the infusion temperature of saline. Here we have -3. And we put this into our equation. Do this again. Voila. We have a flow rate of 65 milliliters per minute for the LAD. Another precision to make here, this principle of thermite dilution is based on the mixing of saline with the bloodstream. And so the point at which this mixing happens is going to be the point at which we're measuring flow. So perhaps counterintuitively, despite the fact that our temperature sensor is down here, the mixing of blood and saline is happening at the tip of the ray flow catheter in the proximal vessel. And so we're measuring flow in the proximal LAD. I hope that's clear. And likewise, if we make a resistance measurement, which we'll show you a bit later, the resistance is going to be the resistance in the LAD, everything downstream from this tip in the proximal vessel, so all that mass that's subtended from the proximal LAD downwards. Okay? Let's change the numbers a little bit to make it a bit clearer. Imagine that instead of 0.05, minus 0.05, we pick up a temperature of minus 0.25 instead. We still have the same other parameters where we're measuring resting flow, and we know that the infusion temperature of the saline is -3. Well, we end up with a flow rate of 130 milliliters per minute. Why does that make sense? Well, if the flow rate is higher, then less saline is going to mix with the bloodstream per unit of blood as it goes past. And so we have a temperature that's much closer to blood temperature than we had before. Let's use another example. Now imagine that the flow rate is slower. Well, as the blood goes past the ray flow catheter, more saline mixes in per unit of blood, and we end up with slightly cooler mix of blood and saline in the distal vessel, which corresponds to a much lower flow rate. Let's talk about the practicalities of how we might do this in the cath lab. We showed you earlier how this works. Just to reinforce a few points, we need a pressure temperature wire. We need the ray flow catheter, this dedicated infusion microcatheter. We need an injector pump that's capable of injecting saline at a very, very dedicated flow rate. So we need 10 mils per minute for rest and 20 mils per minute for hyperemia if we're going to do this in the LAD. We need to infuse at a driving pressure of 300 psi as well. Finally, we need to have the right software to do these measurements. This is the CoraFlow software from Coraventis, which we showed you earlier. And this is fantastic because it very quickly allows you to turn these measurements, if you place these markers in the right place, into flow rates and resistance measurements. It takes seconds, as we showed you earlier on today. So let's take an example. This is a measurement in the LAD. You'll remember what these tracings look like. At the start, before the pump is started, we have a temperature of 0. So we zeroed with the blood temperature. The infusion starts. We induce hyperemia. As you can see, the FFR is now measured here, 0.86. We have a mix of blood and saline that's minus 0.68. We then perform this pullback of the temperature sensor to the tip of the ray flow catheter to get the infusion temperature of the saline. We now have everything we need to calculate absolute coronary flow using this equation here. And that's shown here. We have a measurement of 148 milliliters per minute in the LAD. You'll also see that it's automatically calculated microvascular resistance. How has it done this? Well, we're going to take Ohm's law again. We've rearranged this equation. Resistance is equal to pressure divided by flow. We know the flow rate. We've just measured this. We know the distal coronary pressure, as that's been measured by our distal sensor. It's 75 millimeters of mercury. You plug this into this equation, and you end up with a microvascular resistance of 507 Wood units. Okay. A few more examples. Here's another example. It's a resting flow measurement, so 10 milliliters per minute being infused into the proximal LAD. The temperature signal stabilizes quite quickly. We have a measurement here of T, the mix of blood and saline. We have a measurement here of the temperature of the infusion of saline coming out of the tip of the ray flow catheter. Coraventis rapidly calculates this into a flow rate of 68 milliliters per minute, and we have a microvascular resistance of 1,484, which is a completely normal rest-in microvascular resistance for the LAD. Here's hyperemia for the same patient. Again, hyperemia is established very quickly. We have a very nice, stable tracing where we have T, the mix of blood and saline. We have TI, the infusion temperature of saline after the pullback maneuver, and we end up with a flow rate of 227 milliliters per minute and a microvascular resistance during maximal hyperemia, which is completely normal, of 386 Wood units. I'll quickly show you this. What we just showed you there were two separate recordings, one at rest, one at hyperemia. So you can imagine, because there was a pullback maneuver required to measure the temperature of the saline at the tip of the catheter, that we then have to rewire the vessel in order to repeat the measurements during hyperemia. Well, this is a workaround. If you have a pump that allows you to program flow infusion rates of 10 and then 20 automatically, you're able to do it in one sit-in. So I'll explain this tracing to you. It should make sense to you. We start with a rest-in flow measurement where if saline is being infused at 10 milliliters per minute, the pump then instantaneously changes to 20 mils per minute. So we induce hyperemia, as you can see here. And so now we're measuring the mix of saline and blood during hyperemia. We remain at an infusion rate of 20 mils per minute, and a pullback maneuver is performed. So now the temperature sensor is at the tip of the ray flow catheter. So we now have the infusion temperature of saline when we're infusing at 20 mils per minute. The pump then instantaneously changes to 10 mils per minute. And so we now have the infusion temperature of saline when we're infusing at 10 milliliters per minute as well. So this tracing, I hope it makes sense, gives you everything you need to work out resting absolute coronary flow, hyperemia, absolute coronary flow. We're then able to calculate the CFR because of the ratio of hyperemic and resting coronary flow. And we can also calculate MRR, which Bernard is going to go on to talk about next. So, I gave you lots of numbers, but do they actually mean anything? Well, fortunately, yes. Firstly, is it accurate? How do the measurements of flow from continuous thermodynamics correlate with a gold standard reference? Well, this was a study which was published in the European Heart Journal, which compared continuous intracoronary thermodilution with flow measured by PET. As you can see on the x-axis, we have absolute coronary flow as measured by PET, and on the y-axis, using continuous intracoronary thermodilution. And as you can appreciate, the agreement between these two methodologies was excellent. What next? What about repeatability? If I do a measurement, I stop and I repeat it 5 minutes later, how close are the two values to one another? This is something that is an issue with bolus thermodilution, for example. We know that it's highly variable. Part of that is driven by the operator dependence of the bolus injections. What about continuous thermodilution? Well, this is a really nice study performed by, in fact, Emanuele and Bernard a little while ago, which looked at exactly this point, repeatability of these two methodologies. So on the x-axis, we have various indices, and on the y-axis, the variability between two repeat measurements. And as you can see, bolus thermodilution in red, continuous thermodilution in blue. Continuous thermodilution has much better repeatability as compared with bolus thermodilution. Okay, so to summarize, continuous intracoronary thermodilution, a relatively new technique which allows us to measure absolute coronary flow and absolute microvascular resistance. These are two things that you can't get from the other proxies of flow that we use in invasive interventional cardiology. The values we get are accurate and they're also precise. And it really does provide us with a means of reliably and accurately assessing the microcirculation to get very, very precise, hopefully accurate diagnoses of coronary microvascular dysfunction or excluding coronary microvascular dysfunction. I'm going to stop there and answer any questions.
I saw during the live case that was performed that what is the physiologic base of flow-dependent hyperemia? So you inject 20.
Yeah.
I was not aware about that. Why do you get hyperemia based on the flow
Yeah,
rate?
that's a good question. So exactly. So when you infuse 20 milliliters per minute of saline via the ray flow catheter into the LAD, you instantaneously induce hyperemia. It's something that the group in ALS have tried to understand. From what we know so far, there seems to be a little bit of hemolysis of the blood when you do this. Nothing crazy, but a little bit, which releases adenosine, which seems to be the explanation for the hyperemia induced by that flow rate. Yeah.
So, just a question, just asking for your confirmation. These thermodilution methods, bolus and the continuous, they are calculating the continuous or estimating in the bolus the flow at the proximal part of the coronary artery, right?
Mm-hmm.
I mean, that's correct.
That's exactly right, yeah.
Okay. And this correction factor, 1.08, is just to correct for the different viscosity of the fluids?
It's the density and the specific heat of blood and saline, so how it responds to temperature.
Okay.
Yeah. Yeah.
Okay.
Sorry, you have a specific recommendation about the aortic pressure range that is allowable if you try to calculate the resistance. So if the patient have very high pressure or low pressure, does it affect the measurement?
No, I don't think so. In fact, so the calculation of resistance factors completely in the pressures. So if pressure goes up, we should put that value into your calculation, and it will have an impact on what you calculate. Yeah.
But that's a theory, because in the pulmonary hypertension world, we know that it should be linear, but it's not. So I don't know what's about the coronary.
I don't know much about the pulmonary hypertension research, but in terms of how Ohm's law works and how the interrelationship between flow resistance and the pressure gradient, well, they're all interrelated. So if you have a change in pressure, you need to factor that into your calculation for resistance. That's implicit for me.
Sorry to come back to this flow rate. What is the maximum that has been tested? If I may ask, and
that's a good question. I might direct this towards Bernard.
And was there any kind of a comparison of the vasodilation effect if you do it, for instance, with 10 ml plus adenosine? Because I found this personally exciting. I wasn't aware about that at all.
Yeah, well, use this.
Well, first, I will not repeat what Tabo has said already. When you inject 20, you induce hyperemia immediately. That's almost mechanical. And this is most likely related to the hemolysis of the red blood cells. That is one. The question was, to how far can we go in flow? Well, we did not test, of course, how far before damaging the coronary arteries. But what we know is that we have already experience with 25 and even 30 milliliter per minute of flow, but I would certainly not go higher than that. We did not have real problems with 20. We have published these safety data, but yeah, it's common sense not to give 50 or 60 milliliter. 50 or 60 milliliter per minute, it's a lot of flow through these small holes. You have a jet which goes from here to 3-4 meters. So it is really forceful. Of course, it is within the blood, but nevertheless, I would not even try to do so.
As far as we see, what is the average accepted flow in the coronaries as the blood? That's because we see values
What is
of
the what?
The flow rate in we see values between 60 to 120.
Yeah.
So essentially, if you inject 50 or 60, you will replenish the blood
Absolutely.
completely. So that's another rationale about what kind finally we end up on the percentage of flow that you the percentage of flow that you want to
That's a very good
evolve
point.
into.
There is no. It would be ideal to have to inject only 1 cc, for example. But of course, then the signal-to-noise ratio is not optimal. But you're right, that the average flow in an LED is between 50 and 90, 100, 120. This morning it was a very high flow at rest already. But okay, it was a young guy, as we almost never have in the cath lab, with a huge LED. And you have seen that during hyperemia, it went up to almost 500 cc, as much as in renal artery. It was very exceptional. But this is the range. And therefore, you're right, we should not go to 50, because otherwise we replace the blood by saline. What?
Okay, the next speaker is a new and upcoming name in the coronary physiology world, Dr. De Bruyne.
Yeah, well, I would like to say a few words about microvascular resistance reserve. You're all aware of the CFR, the coronary flow reserve. Here we are going to focus on microvascular resistance reserve. You are going to say, well, this is exactly the same. Well, not exactly. So let's try to explain, and I fully agree this is complicated, especially late in the afternoon, but I'll do my best. So this is something you have seen already a couple of times. The resistance is all we need for the assessment of the coronary circulation, the microcirculation. But we also have to realize that the microvascular resistance is actually not enough for a couple of reasons. The first reason is that the resistance depends on the flow, and we have seen already 10 times that the flow depends on the mass. If the mass is high, the flow will be high and the resistances will be low. Where is the lowest resistance? In an LAD or in a circumflex, you think? A normal resistance? The resistance will be higher in the LAD or higher in the circumflex? Higher in the LAD. Lower in the LED. The mass, yeah, but it's counterintuitive. That's why I put the question. It's counterintuitive. And each time I have to think twice. When the mass is high, the flow is high, therefore the resistance will be low. So the resistance in an all LED will be lower than in a circumflex. Now, this, regardless of these details, it means simply that if we have simply a resistance, as long as we don't know what the mass is, well, we cannot say anything with this resistance. The advantage is that the mass of the LED is relatively standardized, I would say. We have almost the same mass in the LED, more than in the right and in the circumflex. So that's another good reason to measure mainly the LED. Besides the fact that it's a bigger vessel, it's more representative, and so on and so forth. But we have to, that's an advantage of our coronary circulation. So again, if you measure the resistance in the distal part of the LED, well, the resistance will be much higher than in the proximal part. That's the first thing, why the resistance by itself is not sufficient. And therefore, we can correct for the mass. How are we going to correct for the mass? Well, we are going to say, well, let's have a look to the hyperemic resistance divided by resting resistance, or the contrary, resting divided by hyperemia. In other words, we are going to correct for the mass, just like we do with CFR. And the most intuitive thing to do is simply to say, well, microvascular resistance reserve is the resistance of the microcirculation at rest, which will be very high, divided by the resistance during hyperemia. Do you agree? You still follow? Good. Well, that is too easy, because as soon as there is a resistance at the level of the epicardial vessel here, we have seen in the first lecture that the resistance of the microcirculation will adapt. Therefore, as soon as there is the slightest resistance at the epicardial level, the resistance that we are going to measure here is no longer true microvascular resistance. It is a resistance It's a value which has already been adapted by autoregulation. The microcirculation is so smart that it adapts its resistance automatically and instantaneously. And that's important to realize. This is the reason why simply saying, oh, we are going simply to divide resting resistance by hyperemic resistance, this is not correct. That's the whole concept of microvascular resistance reserve. We have to correct these changes for the epicardial resistance, or I'm sorry to be a little bit pedantic, for the epicardial conductance, actually. What is the best index to assess microvascular conductance? It is FFR. And therefore, this is the reason, I'm going a little bit fast, but this is the reason why MRR is defined as CFR corrected for FFR. It is both that simple, but also that complicated to understand why it is the case. And I will not go through all the mathematics to demonstrate that. Believe me, the MRR is actually the CFR divided by the FFR. There is also this correcting factor. It is in case the PA would change between rest and hyperemia. But forget it. Forget this, because this term is almost always equal to 1 or very close to 1, so we do not have to correct too much. CFR divided by the FFR used here opportunistically as an index of epicardial resistance. That's it, okay? And therefore, and I say that already previously during the discussions, to put the diagnosis of CMD in a patient, we have to be very prudent to use only microvascular resistance, but we have to use and microvascular resistance and MRR in conjunction, okay? Or if you are using bolus thermal dilution, well, then you use CFR and IMR in conjunction. If both are abnormal, then you have a point. Then you have a good argument to say that the patient have probably microvascular disease. If it is only a higher, somewhat higher resistance, but actually that your microvascular resistance reserve is strictly normal, well, then probably there is nothing to worry about, and vice versa. The real patients, the real sick patients, the real patients who have a problem with their microcirculation are those where both the resistance is too high in absolute terms, Woods units, and the microvascular resistance reserve is too low. Good. I realize I'm making shortcuts, but it's the end of the day and we are tired. So we have understood also that FFR will tell you everything about this segment, MRR will tell you everything about this, and that CFR is an index which is very aspecific in the sense that when it is too low, it is very difficult to say if it is due to the epicardial stenosis or to a problem of the microcirculation. Now, how to assess MRR and absolute resistance? Well, you can use whatever method which gives you CFR, but actually, as we have seen, the most reliable, the most reproducible, the more precise, which means repeatable, is of course based on continuous thermodilution, as we have demonstrated this morning. But you can use bolus thermodilution, and the Doppler, people can use Doppler theoretically to derive this index of microvascular resistance reserve. Good. This has been very well validated, and this was work that has been done by Emmanuel Gallinoro. This was a lot of work, I can tell you, but anyhow, we have validated, paradoxically, using the Doppler as a gold standard. We still had a couple of Doppler wires available, and we used them to validate the MRR. It works very well, and which, by the way, a contrario proves that the Doppler, when it works also very well. But this has been clearly validated, so I won't go into the details. Couple of data, just to make things clear. IMR, the threshold is 25. We discussed that already with Scholt. Bolus thermodilution CFR is around 2, 2.5. Below 2, yeah, it's probably abnormal. In between, I would be very careful before putting the diagnosis. With continuous thermodilution, we can be a little bit more strict, and the cutoff of 2.5 is, of course, still valid for CFR. Absolute resistance, and that's new. The threshold is around 475. Above 500, it's most likely abnormal. Below, well, we can be relatively reassuring. Again, this has to be evaluated in conjunction with microvascular resistance reserve. And again, there will be always a gray zone for the microcirculation. But below 2.1, it's certainly abnormal. Above 2.7, it's certainly normal. In between, yeah, we have to be careful. These measurements are reproducible. That's the repeatability. Again, I will. And then, what is the most important characteristic of MRR is that, in contrast to CFR, the MRR remains stable whatever the epicardial stenosis. And this is a fantastic experiment that we did with Tabo a couple of months ago. It was published last year in JCC. And to make a long story short, we created a graded controlled stenosis in the LED. We measured the flow, we measured the pressures, and we realized that, of course, and these are the results, and look only at the right panel here, the CFR will decrease. When the lesion becomes tight, well, of course, the CFR will decrease, while the MRR remains constant, which simply means that MRR is an index that you can use to evaluate the microcirculation also in the presence of epicardial stenosis. A lot of information in a minimum of time, but okay, let's summarize. Our understanding of, and our understanding, diagnosis and treatment in CMD has been hampered by the lack of accurate and reproducible metrics. We have said that already 10 times. MRR and absolute resistance measurements are probably a solution. MR should really be regarded as a super CFR, a very comprehensive CFR. And MRR can also be derived from any other reliable invasive and non-invasive method, for example, Doppler, also bolus thermodilution, but of course, the quality of the metrics will be much better when derived from absolute flow as determined by continuous thermodilution. And to end, I use these words looking at the Abbott people, urging them to put this on the console and to endorse this new technology, which is much more precise than what we have on board right now. Thank you very much.
The fact that you're ready to step down means that whether we understood everything or nothing. That's fascinating. Of course, it's an excellence of the developments, but
no, it's getting late, you know. Don't feel obliged to find a question for me.
No. It was not about that. It was not about that. But simply on the practical aspects of it, maybe a public question of what are the rationales of difficulties of implementing in real world the continuous thermodilution? If you don't feel well to answer publicly, please don't. Yeah. But is there any rationale about that?
Well, the only reason why it is not yet available is that the company does not endorse that. I will be very blunt. But the reason why they do not endorse that, I understand that also, because it's a little bit more demanding. In the cath lab, you need a pressure wire. That's, of course, very good for Abbott. But you also need an injector, and you need dedicated software, which is the Coroventis. Now, you really need all three of us. And you need a dedicated catheter, which is called the Rayflow, which is produced by another company, so it makes things a little bit more complicated for Abbott. So that's the main, let's say, limitations of the widespread application of the method right now. But actually, if you call Abbott and you ask or you buy a couple of wires, you have an injector to perform LV angiograms, and you call Hexacat to buy a number of catheters, well, it's up to you to implement that tomorrow. Because it's also important to realize that the absolute flow measurements and all these automatic calculations are already on the Coroventis. So if someone has Coroventis in the room, and probably most of the cath labs are equipped, it is there. You don't have to buy a special license, you don't have to, it's not an additional thing like PPG, for example, which is not yet implemented. Absolute flow is there, so that there is no reason not to do it. Good. I will stop here.
One last question.
Okay. No.
Practical. We see that we can measure the microcirculation in very different ways, but in the practice, if you have a patient with angina, you make FFR and it's positive. Are we going to measure the microcirculation? Because they could be two kinds of dysfunction.
Yeah.
The one doesn't exclude the other.
Absolutely. No, but you're absolutely right. But to be very, very practical, I fully agree that if you have, some lesions there in the epicardial segment, that you have an FFR of 0.70, you have the answer, period. You don't have to make it more complicated than it is. But nowadays, there are more and more arguments to say that, well, actually, the results after PCA are much better when the microcirculation is normal. So this information of the microcirculation will be important sooner or later. And then, of course, there are all these vessels without any significant disease. Look at the patient of this morning. Honestly, I didn't see this osteal lesion. It's only after vasodilating a lot with nitrates that we saw that the osteum was a little bit abnormal. I wondered whether the 0.79 value was an error. It was actually not an error. There was indeed something. But there was probably also something else in this patient. It was diffusely atherosclerotic. Probably this guy, to have so much angina, because he was very symptomatic, had something else. Or it could have been the case, let's say. We have to be prudent. But you're right, we have to remain practical. We have to remain practical and not to make it more complicated just for the fun. There was another question? No other question.
The last comment, well, from this nice trial about the stenosis independency of the MRR, as I see, you're using the model of treating a patient, you're implanting a stent, and then you're able to perform these on top of this. Which is actually, as we said, which is
that's
actually,
a very pragmatic.
That's the way
aspect.
to do it, essentially, in a kind of a way of that makes sense both for serving the treatment and then getting a little bit more data. Well done.
Thank you very much. So now we move to our last presentation from Thabo, who is going to explain us how to practically organize the hospital, the ANOCA clinic, to manage the flow of patients. Thabo, the floor is yours.
Thanks, Frédéric. I think we're killing you slowly with talks about the microcirculation. I'm going to try and do this as quickly as possible. Hopefully this is a practical talk that might tell you how to implement what we've learned today into real life. So how to organize an ANOCA clinic? Well, what do I mean by a ANOCA clinic? I'm not talking about a physical entity or a building, but the expertise and the infrastructure that you need to manage patients who have angina and non-obstructive coronary arteries. So the size of the problem, well, this has actually come up a few times today. In fact, the talk from Neo also addressed this point. What percentage of patients who come to the cath lab with a suspicion of obstructive coronary arteries end up having non-obstructive epicardial vessels? Well, the number that's cited varies, but it's anything from 50 to even to 70% if we're talking about female patients who refer to coronary angiography. Historically, we have to be honest, this is a group of patients that were completely neglected. So they come with suspicion of angina, they have an angiogram, we see no epicardial disease, we reassure them, and we send them home without a diagnosis and without any treatment. It's a bit of a problem if you think about it. There's been a lot of research in recent years to try and understand what's exactly going on with this group of patients, and we now know that there are all sorts of diagnoses that could explain the symptoms of these patients. And now we have the technology at hand to actually investigate establish a diagnosis, and now catching up, potentially some treatments that could change the prognosis, certainly the symptoms of these patients. So here's an overview of what an ANOCA clinic might look like. I'm going to go through each of these in turn, and then we'll go into a bit more detail afterwards. So first of all, you need a general cardiologist, a non-invasive colleague who is genuinely interested in these heart-sink patients who we don't know what to do with sometimes. Someone who's going to be willing to take detailed histories, use the appropriate questionnaires to understand their symptoms properly, and hopefully try and change their symptomology and change their prognosis. Next, we need to carefully select our patients, and this bit's absolutely critical. Like with any diagnostic test, if you can carefully select the patients who are going to undergo that test, where you can maximize the pre-test probability that your subsequent testing is going to pick up pathology, it's obviously much better for everyone involved. I'll go into a bit more detail about what I mean by this in a moment. Next, and this is going to be dependent on which center you work in, if you have access to a CT scanner which can give you high quality images, actually you can have a patient with typical sounding symptoms who can have a CT scan which can exclude definitively that they have any epicardial disease. And you now have someone with quite a clear ANOCA categorization who can then be referred to invasive testing, and we can go straight to the coronary functional testing without wasting any time with assessment of the epicardial vessel. Next, you need to have interventional cardiologists who are experienced in performing the coronary functional testing, and a cath lab that's capable of doing it, with cath lab staff that are capable of doing it as well. Also added onto here a pharmacist, and this is present for a very specific reason. One of the diagnoses in these patients with ANOCA is vasospastic angina. It could be at the epicardial vessel, even at the microvascular level. Sometimes it's a mix of the two. The best drug for trying to elicit this diagnosis is acetylcholine. Now, it's notoriously difficult to get hold of, and you really need a pharmacist on your side to try and get hold of this drug so you can perform this test properly. We need a rehabilitation program, so there's evidence now, increasing evidence, that simple lifestyle modifications might have benefits in this cohort of patients. There's in fact a trial that we're running at OLV at the moment called Exercise CMD that's going to try and explicitly demonstrate that patients with CMD who undergo exercise potentially have improvements in their symptoms and their prognosis. Finally, continuous education. This is important because this is a field that is constantly changing. So every year there's more information about this condition. There's now some increasing evidence about treatments that might change prognosis in these patients. We have one clinical trial now called the CORE-MICA trial, which tried to really demonstrate that if you introduce stratified medical therapy based on the diagnosis you get from coronary functional testing, you can change the symptomology, certainly of these patients, the quality of life as well. So continuous education is important. We need to keep up to date with what's going on in the field. Okay, so how do we organize the clinic? I'm going to start with the patients. Like I said, if you can carefully filter the patients that you're sending for this testing, the higher the chance that you're going to get someone with a diagnosis. So we want patients with convincing symptoms. We've chosen words carefully here. Compelling symptoms, symptoms that are recurrent, and symptoms that are debilitating. If you can pick patients like that, the likelihood that you're going to pick up a diagnosis is going to be higher. If you pick patients that have strange symptoms that you're not really convinced about, high probability you're going to end up with no diagnosis at the end of this. You're going to be wasting a little bit of time. Next, if you have a CT scan, ideally, you would have already excluded any epicardial disease, which means that you can then contact your interventional cardiologist friend and say, I have a patient with ANOCA, we know we don't have any epicardial disease, can I schedule them for coronary function testing? And you can go straight to it. If you don't have that, it might be that you need a first invasive diagnostic procedure to exclude epicardial disease, and then reschedule that patient for a separate coronary function testing protocol, because it's quite a lengthy one, so it may well need a second procedure. Many of your patients might well be patients who have come for a second opinion because they have persistent symptoms and the cardiologist has never gotten to the bottom of it. If you have a coronary function testing program, you might in fact, be able to be the one person that gives this patient a diagnosis. Finally, objective signs of ischemia from non-invasive functional imaging isn't obligatory, but it can be suggestive, and you can use that information. Okay, next. The clinic, and here I'm talking about the infrastructure and the expertise that you have. So I mentioned the clinical cardiologist who's going to play a critical role in evaluating these patients, assessing, does this genuinely sound like angina? Do an objective assessment of the angina using questionnaires. You have your invasive cardiologist who's going to perform the testing, the pharmacist who's going to help you get your acetylcholine, possibly psychological support, because these patients are often debilitated by their symptoms, and it can be helpful to have this as part of your team. A rehabilitation program as well. So what happens? So in your first consultation with your general cardiologist, we're going to take a very, very detailed history. It's going to be a repeat of what's happened before, but we're going to really try and understand what is going on here. Does this genuinely sound like angina to me? You're going to evaluate the risk factors and the lifestyle factors. You're going to try and exclude other potential causes for the chest pain so that you can really filter your population. You're going to use standardized questionnaires to try and objectify this, and this is always important because if you're then going to introduce a treatment, you'll have a baseline comparator to see whether you've actually made a difference for this patient. And ultimately, the decision is going to be, is this genuinely someone who should be sent for coronary function testing? As for the questionnaires that you might use, so there's the Seattle Angina questionnaire, there's a shortened 7-point version or the longer 19-point version. There's a separate questionnaire for patients who have dyspnea, which might be a presentation of angina in itself. There's also the Orbiter app, that's something that's been developed by the team in Imperial College, an app that's downloaded by the patient, which allows them to report their angina symptoms on a daily basis. It's a very, very practical solution I think will be increasingly used. And then ultimately, if you can get yourself a group of patients where you're confident that you've excluded other causes and now you're in a population of patients where there's a genuine high probability that you might have coronary microvascular dysfunction or maybe some sort of vascular spasm, then you're in a really good position to refer this patient to CFT. And this is how it works. This is certainly how it worked in our centre. Firstly, the objective of CFT. If you've got your carefully filtered population now, you're going to hope that by the end of your CFT protocol, you're going to be able to place your patient into one of these 4 categories. Now, the first one hopefully is not a problem, but just in case you had a faulty CT with lots of artifacts, and in the end you stumbled upon a patient with actual epicardial disease, well, you're going to want to go ahead and assess that with FFR, PPG, as we've spoken about today. If you haven't got epicardial disease like you initially thought, the first thing you're going to do is assess for vasospasm using acetylcholine. You can then assess the microcirculation using one of the modalities available. As we've hinted quite strongly today, the ideal would be continuous thermodilution. It's the most accurate and repeatable measure and modality that we have. And then if at the end of all of this, you have a patient with no vasospasm and no microvascular dysfunction, well, you can actually put this patient into a normal category where you can confidently say that this patient has no problem with their coronary circulation. We're talking about the epicardial compartment, but also the microvascular compartment. And that's a great thing to be able to say to someone. Your symptoms are not at all coming from the coronary circulation. And you can say that quite definitively once you've done this. Okay, so let's walk through a CFT protocol. Step 1, well, we're going to want a 12-lead ECG. This is important for the vasospasm testing. You want to have a baseline 12-lead ECG as your comparator, so you can look for any changes in the ST segment during the acetylcholine testing. We might do our procedure via the radial, but it's worth bearing in mind that because we're going to be doing a test of vasospasm, we want to avoid all vasodilators. So you're not going to be able to use your standard radial cocktail, things like nicardipine or verapamil. So if you don't think you'll be able to achieve a procedure with radial access, have a low threshold for switching to the femoral artery. That's one tip that we can give you. Next, we want to have a good idea of LV function before we start it. Like a lot of these patients will have an echocardiography. If they don't, and in our centre, sometimes even if they do, we still perform an LV angiogram to get a good idea on the day of what their function looks like. Are there any regional wall motion abnormalities? Is there a valvulopathy that we haven't understood? because to take advantage to get a left ventricular end diastolic pressure as well. We're then going to perform angiography of the left and the right system to have as our baseline images for the subsequent testing. We're going to do our CFD protocol in the LAD. As Bernard mentioned earlier, the LAD is quite a consistent vessel. The mass subtended by it is very, very similar between patients, whereas if you were to do this testing systematically in the right coronary or the circumflex, you'd have a lot of variability, a lot of changes in mass. That's going to confuse your values completely. So we consistently say, use the LAD. We're going to have a guiding catheter. We're not going to use intracoronary nitrates yet because we're going to do vasospasm testing. So as soon as you've given this, you can forget about your acetylcholine testing being reliable. Right, step 1, or step 2, should I say. Now we're going to test for vasospasm. We're going to use acetylcholine at increasing concentrations. This is the protocol we use in ALS. So try and imagine this in your head. It's a shame we don't have a video of this as we would do it. On your screen, you're going to have your 12-lead ECG so that you can see what's happening to the ST segment whilst you're infusing acetylcholine. You've already performed your angiography. You have 2 projections of the left system. You know what the vessels look like before you've started infusing acetylcholine. We're going to start with a low dose of acetylcholine, 2 micrograms. We infuse this slowly into the left coronary system via the guiding catheter, usually over a period of around 2 minutes. Once you've finished, you're going to clear the acetylcholine that's left in the tubing, and we're going to perform 2 angiographies of the same projections to see whether there's any evidence of spasm in the vessels. We're also going to do a repeat 12-lead ECG and compare it to our baseline to see whether there's any evidence of ECG changes that might suggest that there's something ischemic happening. And at the same time, we have a patient there who might be able to report whether we're getting any symptoms at all. If we have nothing at this stage, we're going to continue. We're going to move to 20 micrograms as the next dose. Again, over 2 minutes, we're going to infuse this dosage, clear the tubing, check the ECG, do 2 projections, see whether the patient is going to report any symptoms or not. And we're going to work our way through these different concentrations to 100 to 200. If we get a patient who has a positive result, I'll go into this in one moment, we're going to stop. If not, we're going to finish the protocol with a dosage of intracoronary nitrates to vasodilate the vessels at the very end before we move on. So what does a positive result look like? Well, there are 3 parameters to think about. The first is symptoms, and we don't just mean any symptoms. What you really want is a patient telling you that they have the same symptoms that result in them being referred to the cath lab in the first place. If a patient reports the exact same symptoms that they have in daily life, you can be more convinced that this is not just an incidental finding from high-dose acetylcholine, but perhaps the real cause of their symptoms, vasospasm in real life. Next, you want to have ECG changes, ST segment changes or T-wave inversion that suggestive of ischemia. And the final thing you're going to be looking at is whether you get significant spasm, which we define as a diameter reduction of greater than 90%. So, scenario number 1, epicardial spasm. You have a patient who reports symptoms that are completely recognizable as what they have in daily life. They have ischemic ECG changes at the same time, and severe reduction in diameter, clear vasospasm on angiography. There's another scenario. You have a patient who has recognizable symptoms, clear ECG changes, but they don't fulfill the angiographic criteria for vasospasm. Well, this is a patient we could potentially put into the microvascular spasm category. You could also have a patient that has no symptoms, no ECG changes, and no reduction in diameter on angiography. There we can quite clearly say there's no spasm. And you may end up with a group of patients where you have a mix of the other combinations, and there you really can't be so conclusive. So let's have a look at some examples of what some of these things might look like. Here we have an example of epicardial spasm. This patient had quite a normal looking angiography at baseline, and then had quite typical symptoms, very ischemic ECG changes, and then you can imagine this is quite clear vasospasm of the whole left coronary circulation, which resolves with the quite quick administration of intracoronary nitrates. Here's an example of microvascular spasm. again, quite normal looking arteries. The patient reports symptoms. We have quite clear ST segment changes, but no clear evidence of epicardial spasm. There's one interesting comment I'll make about this. I'm sure you can see that the flow in the LAD is reduced. I'd call that TIMI2 flow. It's quite a marked example where there's something going on in the microcirculation. There's a change in resistance, but nothing going on in the epicardial compartment that explains this patient's symptoms. Right. The final bit is the microvascular assessments. We've spoken at length about this. I'm not going to labor it any further. There's bolus thermodilution, there's continuous thermodilution, there's also intracoronary Doppler. To remind you, this is probably the most widespread technique that's used. It's fast, it's quite cheap, it's quite easy, it's highly operator dependent. We've demonstrated that it has issues with accuracy and repeatability, but perhaps for many centers it's the best that we have. Then we have continuous thermodilution, which we know is very, very accurate, very, very precise. It takes longer, it's more expensive, there are issues with availability of the kit. I think the practical point to mention here is it really depends on what you have available to you. If it's bolus, then use bolus. If you have the luxury of continuous thermodilution, certainly use it. I won't show this again, Bern, I mentioned this before, but these are the various cutoffs that you can use for the indices. Finally, to close the loop, once you've completed your CFD protocol, you want to carefully detail what you've found and what you've not found so that you can send this patient back to the referring cardiologist and hopefully make changes to medication and change their prognosis. So, in this example of a report, we've mentioned that the LV function is normal in this patient. We have a value of the FFR, which we know is above 0.8, mildly irregular vessels. We found no spasm in the vessels with acetylcholine testing, but we have a diagnosis of CMD with a CFR which is 1.9, an MRR which is also low, and a raised minimal microvascular resistance as well. We're going to send this patient back to the referring physician with quite a detailed report where we can tell them something definitive. So, to conclude, the Anoka Clinic, this concept, is really about infrastructure and expertise. One, we need to make sure we're carefully selecting our patients. Two, you want to have the right people involved, whether it be general cardiologists, interventionalists, pharmacists, and you want a cath lab that's equipped with the right technology and the right expertise to perform the coronary function testing. And I think that's it. Yeah, thank you.
Thank you very much for this very useful approach. One question is, in the guidelines mention another endotype, which is the endothelial dysfunction. And they mention that it is in this category if the response to the low dose of acetylcholine is paradoxal. So we should see some vasodilation with the low doses. If we don't, then we have endothelial dysfunction is one of the few categories where they recommend a specific treatment in the guidelines, ACE inhibitors and so on.
Yeah.
Is it correct? So
yeah, so that's right. So if someone has a vasoconstrictive reaction to the very first dose, then yeah, you could just, well, the whole premise of acetylcholine is that it should be a vasodilatory agent in patients with normal endothelial dysfunction. So if you infuse acetylcholine and you provoke the opposite, constriction of the arteries, then by definition it's suggested that there is something wrong with the endothelium. So yeah, absolutely.
In your overview of diagnostic criteria, there is ECG changes. Is it any ECG change, or is there any cutoff for ST elevation, depression, or whatever?
So I think from personal experience, I think I've seen pretty much everything. So I showed you an example earlier where the patient with microvascular spasm, where there was quite clear ST elevation, looked a bit like a STEMI in fact. The typical thing we tend to see in the lab is ST depression, a bit like what you might see with exercise testing, if you ever do that. I would use the same criteria as you would with ergometry, so exercise testing. If you have suggestive ST elevation or ST depression, then that's quite convincing evidence that there is something going on that's ischemic.
I assume that you do the acetylcholine protocol before the microvascular, technically to avoid the vasodilators.
Absolutely. So it's very specific, the order that we've done that in. It's also important to notice that when we do the acetylcholine testing, there is no wire down the LAD, because having a wire is irritative and it can sometimes trigger spasm. When we perform
you had that in your example.
Yeah,
plus the
true.
stent.
There was, you're absolutely right. It's well spotted. There was a wire at the proximal of that
the proximal LAD over there.
What we normally do, we don't have a wire
so
down
actually
the
this should not be.
Yeah.
It triggered me just to see that, can you do these when you treat, for instance, as is in this case, you have the stent, and then post in patients with established coronary artery disease that they can be treated and they have persistence of symptoms. Are these reliable measures, just like the acetylcholine protocol?
You're talking about spasm, or you're talking about the microcirculation?
I'm talking about both.
Both, yeah. I think it's a completely valid thing to do. So if you have a patient, I think it was mentioned earlier, that it's possible for someone to have both pathology, so something wrong with the epicardial vessel and something wrong with the microcirculation. The logical thing to do if you have an epicardial lesion is to treat it. It's a low-hanging fruit you can treat. You can remove that epicardial resistance. If your patient is still persistently symptomatic and it sounds like angina, absolutely you should assess the microcirculation. It could be particularly relevant, for example, with someone who's had a myocardial infarction in that territory. It might be that there's damage to the microcirculation following this infarction, and so the microcirculation is actually unwell.
Congratulations for this really great talk. How sure can we be that if we take the LAD and measure and everything is normal, then it's going to be normal in the right coronary artery as well? So if you see a patient who is a good enough candidate for you to undergo a CFD, and you do vasospasm testing, it's negative, you do the microcirculatory assessment, it's negative, can you just say that it's going to be the same for the right coronary? If it's a huge right coronary artery, it's a dominant right coronary artery?
I think, I wonder what Bernard would say about it. I think my temptation about just doing it in the LAD is, I think, based on what we've spoken about before, about mass. I think there's a couple of things I'll say. One, there might be a particular reason that you want to evaluate the microcirculation in a vessel that's not the LAD, and an example of that might be if there's been an infarct in that territory and the patient's still reporting symptoms. Imagine a patient has a STEMI in the right coronary artery, you have a normal LAD. Let's say you do a microvascular assessment in the LAD and it appears normal. Well, there's an argument that there could be localized microvascular dysfunction in the territory of the right coronary artery. And in that particular context, maybe it's valid to do an assessment of the microcirculation in the area subtended by the right coronary artery. Second thing I'd say is that there was a study done relatively recently, I think, where they tried to do microvascular function testing, CFT, in every vessel. Bernard, I'm sure you know what I'm talking about. And what they cited in their conclusion was that they picked up more microvascular dysfunction if they tested every vessel than if they just did the LAD, which suggests that sometimes you can pick up dysfunction in one but not the other. I don't think we know enough about it yet, to be honest. I think there's more to come.
I saw that also in the first talk from the colleague from, and also your slides here, that at the end of the day there is almost anymore you able to find a cause in around 80% of the patient, but there is a 20% that remains in the shadow. Any way of, is somebody dealing with that? Any ongoing research in that direction? Any thoughts about what is going on in the patient because you have excluded everything, epicardial, micro, this, that?
Yeah.
So there is still something remaining, 1 out of 5. Yeah.
So I think the first thing I'd say is, if I'm being cynical, one of the reasons why we might have a cohort without a diagnosis is because perhaps we're not using the right test. I think we've hammered you with the benefits of something like continuous thermodilution over bolus thermodilution, because there is sometimes a discrepancy. It might be that one gives you a pathological result and one doesn't. I would go for the gold standard test. Now, take the scenario that we've taken the gold standard test and we've excluded epicardial and microvascular disease and we've excluded spasm. I think you could be fairly confident that that remaining percentage does not have a problem with their coronary circulation. I think that's a very reasonable conclusion. I think the answer is that 20% doesn't have true angina. They have something else.
just another remark in the meanwhile. The guidelines, if I recall correctly, they say, for the adjudication, either angina or ECG changes plus the abnormal results. However, I saw that in your slide you require both of them.
You're talking about spasm?
Yeah, exactly. So I guess it's based on your experience.
Well, I think I'm the student of Bernard de Bruyne, so it's more his experience. But I think you're likely to have a false positive, I think, if you're just relying on ECG changes that the patient doesn't have symptoms. For me, that's very bizarre. So someone's been referred to you with chest pain, and you're suspecting vasospasm. You do an acetylcholine protocol, you provoke spasm or provoke ECG changes, but you don't have symptoms. For me, that doesn't sound quite right to me. I'd say that you're going to have a false result there, a false positive.
Yeah, so I have a question about the acetylcholine protocol. For practical reason, I had to shorten it a bit when I started it back to Italy in the way that now I use only 3 doses, 20, 50, 100. But I've seen that in some papers, they usually say that actually are necessary 2 injections, and they suggest to do 50 and 100. What do you think? Is it feasible to shorten it? Do you have any advice, or is better to stick to that kind of protocol with more injections?
I'll probably refer this to Bernard in a moment, but I think the very first dose, the very low dose, is quite a good test just to make sure there's going to be no abnormal, crazy reaction to acetylcholine. So it's almost a safety dose, the very first one. But other than that, I think probably feasibly it would be possible to shorten the protocol and eliminate some of the doses and go straight to higher ones once you've got through that safety dose. But I'll let you answer, Bernard.
Well, I think that what is important to realize is that there are low doses and high doses. And the low doses, which go to maximum 50 mics, that's already a lot, in my opinion, are really designed to test the endothelial function. And endothelial function and spasm can be associated, but it's not exactly the same. Endothelial function refers to really the inner layer of the vessel, which are abnormal and which induce a paradoxical vasoconstriction. Does not mean a spasm. Higher doses, you expect spasm. Or the reverse, if you have no spasm with higher doses, you can be really reassured. So low dose is, in my opinion, 20, maybe 50. Higher doses is 100. There are many centers who are not going higher than 100. And then, concerning the criteria for spasm, for me, the number 1 criteria is chest pain. If you have a patient telling you, oh, that is exactly what I feel in daily life, what is this? That's exactly, please stop this chest pain, well, you have your diagnosis. If they have chest pain and they say, wow, I've never seen that in daily life, what is happening here? Well, you also have your diagnosis. It has nothing to do with spasm. Okay? So the chest pain and the integration of the patient during the procedure is critically important. The second is, of course, what you see on the angiogram. If you have a complete disappearance of the vessels, you know what's going on. The ECG, in my opinion, I would be tempted to say forget about it, because it's so aspecific. When you inject contrast, you have ECG changes. When you inject the acetylcholine, even slowly, you have ECG changes. You stop, it disappears immediately without chest pain. It's aspecific. Of course, if you have persistent ST elevations, which go along with angiographic images, which are suggestive, okay, you have your diagnosis. But the ECG by itself is not very specific, in my opinion, but that's a bit experience.
I have 2 very short practical questions. Do you use radiolucent ECG leads for the anterior leads during the catheterization?
Radiolucent ECG? I don't think so, no.
Yes, we do.
Sorry, say that again? Yes.
Yes, we do.
Yes,
Okay,
okay.
fantastic.
And second question, I guess most of the patients coming to us for a coronary angiogram will have their CT done before. In our center, this is our minority of patients. Of course, yes, we do, but of course we will cath patients mostly with positive CTAs. Unless you end up set up an end-of-a clinic, we will not cath patients with completely normal CTAs. But if you see a patient and cath a patient who comes in for typical angina without a CTA, do you do the CFD testing in the first setting, or do you schedule this as a second procedure, as a state procedure for practical reasons?
The latter, we schedule. And one of the chief reasons is because acetylcholine takes some time to prepare for the pharmacist, so it would never be available for you like that. Second reason is it's a long protocol, and it might not be in keeping with your schedule that day. So the best thing to do would be to do your diagnostic and then to reschedule for another day.
Okay, if there are no more questions or remarks, we thank once again the speaker for the excellent talk.